طيب ماشي. So HCM is usually a genetic disease with over 50% of the cases having a firm genetic diagnosis. And this percentage will only rise over time as more and more variants are discovered. In order to understand the genetics of HCM, we have to look at which genes are causing the pathology, the journey from the gene to the disease, that is how the genotype links to the phenotype, and how can we use all this knowledge in our daily clinical practice. We know that 60% of the cases have a sarcomeric protein gene mutation, and this is dominated in particular by two genes, the myosin heavy chain and the myosin binding protein. But do all abnormalities in these genes code for a pathology? That means if we do a genetic test to any individual and there's any sort of abnormality in these genes, will this mean that this patient will have HCM? Well, actually, no. That's why we have to classify the abnormalities in these genes into pathogenic or likely pathogenic. That is, it's definitely linked by research to the disease, or non-pathogenic, that's the opposite. It's definitely not linked to the disease by research. And variant of unknown significance, this is in between both. But even beyond the 60%, the other 40% could also have a genetic basis. HCM phenocopies, these are diseases that present with an HCM phenotype, such as Fabry and Danon, also have a genetic basis. Even the unknown sector, this could be something called polygenic HCM, where there is no frank single gene that's causing the HCM, but it's smaller and weaker genes, but the combined effect of them causes the HCM. Or it just could be an undiscovered variant. And like I said before, the more and more we discover newer variants, the smaller the unknown sector is going to be. So how does the genotype translate into the phenotype? Well, we have to look at the gene characteristics. If we take 10 offspring from an HCM patient, the chance that one of these offspring inherits the gene, this is according to the inheritance pattern, which is autosomal dominant usually in HCM. That means 50% chance of inheriting the gene. Now, if this young person inherits the gene, there's something called penetrance that dictates the chance that this person who has the gene will develop the disease. If the gene has complete penetrance, that means anyone who has the gene will always develop the disease. If there's incomplete penetrance, this means that there's a chance that they do not develop the disease. Then there's something called expressivity. Expressivity is examining those who develop the disease, they have the gene and they develop the disease, how severe the phenotype is going to be. Will all of them develop the full-blown picture of HCM or not? If all of them develop the full-blown picture, this is narrow expressivity. If some of them develop mild, some of them develop moderate, some of them develop severe, then this is broad expressivity. There is a large amount of variance in the penetrance and expressivity of the various mutations that cause HCM. So how can we use this knowledge in our daily practice? يعني أعمل إيه يعني? So the typical answer is just family screening, but actually it's much, much more than just family screening. We can use it in diagnosis, especially in borderline cases. If a patient has a 13 or 14 millimeter hypertrophy, this is not enough to diagnose HCM on its own. But if we have a genetic diagnosis, this is enough. We can also diagnose certain HCM phenocopies only using a genetic disease, such as Danon disease. Of course, in phenonegative patients, the genetic diagnosis is basically the diagnosis. It can also be used to inform the prognosis. Sarcomeric mutations are associated with more adverse events, and even within the sarcomeric mutations, each mutation has a slightly different phenotype. And of course, if we discover a phenocopy, each phenocopy has its own prognosis. It can also be used to inform reproductive advice to the patient, the inheritance, penetrance, and expressivity that we mentioned. This can all be counseled to the patient. The patient could be counseled on all of this. And of course, any offspring can be enrolled into a screening program. Finally, it can be used to guide management, whether treatment of specific HCM phenocopies, the frequency of follow-ups, providing psychological support and counseling depends on the genetic test. and the development of something called precision medicine. Well, what is precision medicine? Precision medicine is basically medicine that is tailored to the specific disease. So not beta blockers, which are used in hundreds of different diseases. No, this is specifically for HCM. So in order to understand the use or the appeal of precision medicine, take a look at this example. Would you rather go to a retail outlet and try on just different suits off the shelf and just see which one fits and take that home? Or would you rather contact a tailor and have one tailored exactly to your measurements? This looks much more appealing. Would you rather go buy a mass production car where you just select the color and the trim level out of 3 trim levels? Or would you rather have a handmade, tailor-made car that is designed exactly to your preferences? Different hundreds of customization options. Well, it's the same in HCM. We actually have a precision medicine in HCM already, and this is the mavacamten and aficamten. These are drugs designed specifically for HCM. But what if we can take this a level above this with gene therapy? Gene therapy is not science fiction. We already have gene therapy in various diseases. So they are already approved and in use, actually. In beta thalassemia, I can't read the names, so never mind. Beta thalassemia, spinal muscular atrophy, multiple myeloma. These are already drugs that are present and they are being used. So why is gene therapy appealing? We'll take a look at why it's appealing for the companies and why it's appealing to the patient. It's appealing for the companies because the number of mutations or the genes that are implicit in HCM, 70% of them are just 2 genes. So fewer targets are available for the treatment. Number 2, gene testing for HCM is now widespread. Even here in Egypt, a developing country, we already have gene testing in Aswan Heart Center, and we do this to all HCM patients. So it's easy to identify who will benefit and link them to the treatment program. And HCM is not some obscure disease that's very rare, 1 in a million. It's a 1 in a 200 incidence or prevalence in the population. So it's much more cost effective to develop gene therapy for this disease. For the patients, unfortunately, till now, with all of the advancements in medicine, there is no treatment that stops the hypertrophy progression. So there's a need for this specific treatment. Some patients, unfortunately, are at a dead end. We tried beta blockers, we tried calcium channel blockers. They are contraindicated for myectomy. Many of them are at a dead end. This is a single dose treatment as opposed to lifelong treatment with different medications. And HCM diagnosis, even in extremely stable asymptomatic patients, will inform life choices, unfortunately. They can't become, for example, commercial pilots. So very simply, we'll take a look at what potential gene therapies can be developed in HCM. If there's something called a nonsense mutation, this means it's a mutation that causes the gene to not produce anything at all. In this case, then it's just as simple as adding the normal gene, and the normal gene will be produced as normal, and this is gene replacement. Or if it's a missense mutation, that is, it's a mutation that causes the gene to produce strange proteins or abnormal proteins. Then we'll just stop this gene from producing the abnormal proteins. And this is with gene silencing or exon masking. Or finally, we can just repair the gene with gene editing. So actually, many of these are under investigation in HCM. This is not just something that's that we're just thinking about. These are not just thoughts. There are actually experiments on this. So for gene replacement, for example, in neuron models, hypertrophy was actually delayed by using gene replacement. And there are multiple phase 1 trials also on gene replacement or various HCM genes. It's the same for gene silencing and exon skipping. Gene silencing is basically a small interfering RNA that inactivates the abnormal mRNA. And again, on mice experiments, it delayed hypertrophy and diastolic dysfunction. Exon skipping is basically hiding the gene and stopping it from being expressed. And again, on mice models, it transiently prevented the hypertrophy. And of course, there's the CRISPR or Cas9, which is all the rage these days, gene editing. This is basically a complex that actually damages the gene and allows the body to repair the gene on its own, to repair it to the normal gene. And again, on mice models, it delayed the hypertrophy and extended actually the lifespan of the mice. The challenges of gene therapy include, of course, the immense cost. These are the most expensive drugs available on the market. The vector that is used to develop, to deliver the genetic material could incite an inflammatory response, or worse, it could, the patient could have neutralizing antibiotics, rendering it completely ineffective. With CRISPR, since this causes DNA damage, it could also cause DNA damage at areas beyond the HCM gene, and this can cause mutations. And there are some HCM patients who won't benefit beyond these two genes that we have described. And of course, there's always the ethical considerations that are associated with gene editing. So my take-home message is that an HCM patient is more likely to be genetic than not. More than 50% of them are genetic. Genetic tests are helpful beyond just conventional family screening, and gene therapy provides hope to cure or prevent what is something that a patient was always had to live with. Thank you very much.
شكرا على المحاضرة الشيقة دي. أنا بس عاوز أسأل إيه قواعد البنترنس؟ يعني في قواعد للإنهيرتنس، طب البنترنس بقى إيه إمتى يبقى فولي بنترنت وإمتى يبقى بارشلي أو نون بنترنس أطول؟
هو ده بيختلف يا دكتور على حسب فهمي. يعني هو بيختلف من ميوتيشن لميوتيشن. في ميوتيشنز بيكون كومبليت بنترنس، ان هو يعني اي حد عنده الجين ده، اي حد لازم عاجلا ام اجلا هيجي له HCM، فده الكومبليت بنترنس. في بقى اللي هو الليفل اقل اللي هو الانكومبليت بنترنس، ده بيكون معناه ان انا لو عندي الجين حتى لو هو اوتوزومال دوميننت وكل حاجه، بس مش شرط ان هو يعمل ال HCM فينوتايب، فده اسمه incomplete penetrance. يعني انا لو جبت ال10 اوف سبرينج دول وخمسه منهم مثلا inherited الجين، لو ثلاثه منهم developed الديزيز واثنين لا، فده ايه incomplete penetrance. انما لو كلهم developed الديزيز فده الcomplete penetrance.
ودي خاصيه للجين او الميوتيشن دي.
بالظبط. هو على حسب الدكتور طبعا من عائله لعائله. ممكن عائله نبص على البيدجري بتاعتها نلاقي ان هي واخده اللي هي الاوتوزومال دومين او مندليان انهيرتنس، زي اللي هو كتاب ثانويه عامه، نفس المنظر بالظبط. انما في ناس تانية لا، الفاميلي هيستوري رغم ان هو اوتوزومال دوميننت وكل حاجه، بس لا، بس في مثلا ناس واقعه في النص المفروض ان ثيوريتيكالي كان يجي لها الديزيز بس ما جالهاش رغم ان هي عندها الجين.
في اي اسئله ثانيه من
اوف سبرينج دول اللي جالهم برسنت معينه يبقى ده هيجي لهم دول مش ولا مش
ما هو ده اللي احنا بنتكلم عليه اللي هو البنترنس، ان هو من الاخر هو كام في المية فرصه ان الشخص اللي عنده الجين يجي له الديزيز. الجينات او الميوتيشنز، مش الجينات، يعني ميوتيشنز اللي عندها 100% او كومبليت بنترنس، ده معناه ان 100% ده عنده الجين يبقى والله العظيم هيجي له الديزيز مثلا. انما لا، في ميوتيشنز ثانيه ممكن عنده الجين بس مش شرط ان يجي له فرصه 75% 50%.
حتى في 70% اللي هم يعملوا ميوتيشن دول ما لهمش برضه
هو هو
زي ما احنا عارفين ال HCM جينز حتى لو هم هيتيروزايجس فهم اوتوسومال دومينانت، هيبقى في percentage 50% in every offspring to have the disease or not to have or the gene or not to have the gene. If it is homozygous, I think the incidence is much higher. It's some sort of complicated manner.
هو بس انا كنت عايز برضه اقول لحضرتك، هو الفاريانتس اللي بنتكلم عليها دي within الجينز. يعني احنا شفنا مثلا في الليسته هنا 12 جين مثلا، في 2 منهم هم اكبر حاجه. الفاريانتس دول within الجين، يعني مايوسين هافي تشين مثلا ده في فاريانتس كتير جدا، فممكن لحد اعتقد 1400 فاريانت موجودين دول within ال 12 جين دول. يعني انا within ال 12 جين كل جين منهم في فاريانتس كتير. لدرجه ان في عائلات بيبقى عندها فاريانت اكسكلوسيف للعيله دي بس. في بيبرز على كده ان هو عيله نفسها العيله دي بس هي اللي عندها الفاريانت ده، مش موجود في حته تانية في العالم، وفي منهم في مصر على فكره. هو انا فاهم قصد حضرتك ان هو هو الجين نفسه فيه سايتس اوف ميوتيشن مختلفه او انواع ميوتيشنز مختلفه، بس في الاخر هو الجين ديفكتيف، هو على حسب الجين ده بيكسبرس حاجه مش بيكسبرس حاجه. انا ممكن انتروديوس الجين نفسه النورمال مثلا على بعضه، فهو يعني ممكن حتى لو في فاريانتس كتير.
شكرا دكتور عزيز. الحديث شيق بس لازم عشان الوقت نستمر.
شكرا.
بسم الله الرحمن الرحيم. Second speaker, Professor Ahmad Dardir from Romania, will talk about imaging in the modalities and diagnostic innovation.
اوكي تمام. اوكي
I'll speak about multimodality imaging in HCM, how to collect the puzzle pieces. We will try to answer some questions. Why are the walls of the heart thick? Why it is important to know the underlying etiology? Is it athlete heart or HCM? And how to collect the puzzle pieces to reach the diagnosis. SCMR is able to differentiate between different types of amyloidosis and what is the diagnostic key for each individual disease. Let's start with question with a price. Spot diagnosis please in 1 second. Can we know the diagnosis? Okay. Yeah. Of course, it is very difficult. It's just thickened LV walls. Maybe hypertrophy, maybe infiltrative disease or storage disease. Hypertrophy, genetic, which is HCM, or hemodynamic endocrine, or infiltrative disease, of course, amyloidosis, or storage disease such as Pompe-Danon, mucopolysaccharidosis, and Anderson-Fabry disease. So, thickened LV walls, but I want to know what is inside. This is the most important. What is inside these LV walls? And why it is important? Is it just academic talk? Of course, no, because novel therapeutic options really have changed the game. I'm not going to mention because this will be mentioned in the next talk. Secondly, to prevent sudden cardiac death, especially among athletes. We saw before on TV, players died during sport. So, for example, Eddie Carey, they did echo for him, showed HCM versus athlete's heart. They asked the 3 experts, one of them asked for genetic testing, but Eddie refused. That's why Chicago Bulls asked him to go to home and not to practice. So how to help Eddie? First of all, to collect the puzzle pieces from history of high-level sport. ECG, you know the ECG changes because they have high vagal tone and the anatomy, of course. A lot of details, but I want to stress on the LV wall thickness doesn't exceed 14 millimeters and normal strain and normal diastolic function. No late gadolinium enhancement usually, and with follow-up, LVH regresses after deconditioning. So, this is the comparison between athlete's heart and HCM. Both of them increased LV wall thickness, atrial remodeling, systolic function is normal in both. However, strain is normal in athlete's heart, diastolic function is normal, and extracellular volume is high in HCM versus low in athlete's heart. So echo and CMR can help a lot. I'm not going to mention the hypertension, but the patient with LVH with long-standing hypertension and regression of this LVH after optimizing medical therapy for hypertension, this will point towards the underlying etiology, that it is long-standing hypertension. Okay, let's collect the puzzle pieces. As our professors taught us long years ago, start from the history, from the patient symptoms, examination, ECG, family history, then going to imaging to pick the HCM phenotype. Can ECG help? Yes, latest guidelines showed some ECG findings which can point to the specific underlying disease. For the sake of time, I'll pass this and I'll mention just this example. If you have thickened LV wall and low voltage ECG, this directs your mind to amyloidosis and ATTR subtype. Pseudo-infarction pattern, can you see the anteroseptal leads with AL amyloidosis. So we have now clinical suspicion, going to the multimodality imaging. Doing echo and CMR will diagnose the disease, and also CMR will characterize the nature, the tissue characterization. And if you suspect amyloidosis, do bone scintigraphy to confirm your diagnosis. Don't forget the lab. It's one of the puzzle pieces. There is first level laboratory tests, and when you suspect underlying disease, choose the specific test and send it to the lab. For example, Anderson-Fabry disease, there are extra cardiac red flags. So you are approaching the patient and then doing step by step echo, then CMR. I'll confirm on this finding. Can you see here this basal infralateral late gadolinium enhancement? It's present in 50% of cases. And the native T1 is low, and this is the only disease with low native T1 and extracellular volume. We can measure it. What's about amyloidosis? You will have thickened LV wall plus one of those pieces of puzzle. Go to history if the patient have bilateral carpal tunnel syndrome, then doing echo and CMR. You can measure the strain by speckle tracking echo. You can measure the strain by feature tracking CMR. You will find apical sparing. What does this mean? Can you see this? All of you know this, of course. This is spared apical strain, while can you see the mid segments and the basal segments? And it's also one of the red flags. So CMR, what can add to the diagnosis of amyloidosis? All of us read in the guidelines, it's difficult to null the myocardium. You try to, after injecting the gadolinium, to make the myocardium black, to see the white abnormal myocardium. Oh, you will find it difficult. You ask the technician, please repeat it again. Oh, it's very difficult. If less severe disease, you will see global subendocardial late gadolinium enhancement, and you can measure the atrial septal thickness. It can be more than 6 millimeters. So, is CMR able to differentiate between AL and ATTR? Theoretically, yes. Based on the LV mass, the septal thickness, the late gadolinium enhancement, which is less extensive in AL amyloidosis and more extensive in ATTR. And there is a score to quantify the late gadolinium enhancement. Native T1, native T1 also, it's longer in AL amyloidosis. Extracellular volume is less in AL amyloidosis. And this is the quantification of late gadolinium enhancement. Oh, where is the nice black myocardium and the white blood pool and the late gadolinium enhancement in the myocardium? Oh, we can't null the myocardium actually. So try to suspect amyloidosis. Here, can you see? Subendocardial. It's usually diffuse, not in the territory of a certain or a specific coronary artery. And can you see the T1's prolonged high native T1 and extracellular volume is increased. So we have now signs, symptoms, ECG, echo, CMR, do bone scintigraphy and hematologic tests. Bone scintigraphy will confirm the diagnosis. Also, Massiera added the cardiac sarcoidosis as one of the differential diagnoses of LVH. So, can you see the typical spotty enhancement at the sites of granulomas? You will find hypertrophied local hypertrophy with basal thinning and spotty diagnosis at regional wall motion abnormalities areas, not in keeping with ischemic etiology. So we excluded all the causes. Now it's easy to diagnose HCM, which has increased LV wall thickness more than 15 millimeters or more than 13 millimeters in familial HCM. And you know septal to lateral wall and apical to basal thickness. Some tips and tricks in the diagnosis. Late gadolinium enhancement at the insertion point of the RV, can we see here? And here, very bright, very clear. So this segment is hypertrophied, and there is late gadolinium enhancement at the anterior insertion point and inferior insertion point on the right ventricle. SAM with LVOT obstruction and also the myocardial cracks. This is the native T1 in various diseases. Can you see to differentiate between Anderson-Fabry and HCM and amyloidosis? It's a wonderful slide from the EACVI handbook. So to recap, diagnostic keys. If you found posterolateral late gadolinium enhancement and low native T1, diagnosis is Fabry's disease. If you found diffuse subendocardial late gadolinium enhancement and difficulty of nulling the myocardium and high native T1, so it is easy to say cardiac amyloidosis. What's about patchy mid-wall late gadolinium enhancement in the hypertrophied areas and myocardial crypts? It is, yes, HCM. Yeah. Thin basal interventricular septum by echo, and then you did CMR, you found spotty enhancement. It is sarcoidosis. Okay, I'm finishing. Just extra 1 minute, please. Yes. Very subtle focal intramyocardial fibrosis in the basal septum with long-standing hypertension. And finally, athlete's heart, we covered it in details. So, going back to our case, 53 years old, no family history of HCM, presented with NIA function class 3, shortness of breath. I asked you about the diagnosis. It's increased wall thickness with mid-cavitary gradient. Then, can you see there's no sherry on top. So, this patient with CMR confirmed the diagnosis of Anderson-Fabry, with genetic testing and lab also confirmed the diagnosis, septal reduction. Surgery and the pathology confirmed the diagnosis, it's Anderson-Fabry disease and aortic cancer. Thank you.
Thank you very much. الحقيقة فيها a lot of information يمكن محتاجة وقت أكتر.
Sure.
لكن الحقيقة في بوينت مهمة قوي من collection of data you use اللي هي البريدكتورز of sudden cardiac death in HOCM. based بقى على history ECG وإيكو وcardiac.
Exactly.
Can you summarize the predictor of sudden cardiac death?
Yeah, it's usually it's a calculator online. It will ask you about from the history from reported VT, septal thickness, syncope, true syncope.
أكتر من كام بقى؟
Septal thickness it was cut off
لا
30. Yeah.
محطوط في الجايد لاينز كبريدكتور of sudden cardiac
Yeah. Usually I use the calculator in my mobile phone because my mind doesn't keep numbers. In the last of two years, my mind doesn't keep the numbers. That's why I use the calculator on my mobile phone for calculating the risk for every patient in HCM patients, or even to 10 years atherosclerotic, and a lot of calculations. So I use my mobile phone. I don't keep the number. I'm so sorry for this. But it's a very valid point, of course. And the challenge was to explain all of this in only this short time. Every title needs a session alone.
يعني هما زي ما حضرتك قلت غير بقى اليوز بروجرام ولا حاجه لو في سينكوب او فاميلي هيستوري سادن كاردياك ديث او لو الانترفنتريكولار سيستم اكتر من 30 او في الكاردياك ماجنتيك ايميجنج لو مور ذان 50% في فايبروزس او وجود ايبيكال ثيننج او ايبيكال انيوريزم ولو اتعمل هولتر 24 او 48 اور
the VT
ثلاثه انها يا prolonged اكتر من 10 بيتس او فريكوانت اكتر من 3 مرات او الهارت ريت يعدي ال 200. ده يمكن سمبل clarification
yes, to low risk, moderate risk, high risk, and if it high risk, ICD. Okay.
حد عايز يسأل؟ Thank you very much.
Our next speaker is دكتور أحمد دسوقي من أسوان هارت سنتر ويكلمنا على النوبل فارماكولوجيك ثيرابي. دكتور أحمد.
Good afternoon. I'm Dr. Ahmed Dessouki, cardiology specialist at Aswan Heart Center. هنتكلم على novel pharmacological therapy for hypertrophic cardiomyopathy. Our agenda is discussing the current management strategies, the need for new therapy, mechanism of action of cardiac myosin inhibitor, pivotal clinical trials for mavacamten, and does the mavacamten challenge septal reduction therapy, the most recent guidelines recommendation involving mavacamten in the treatment algorithm, indications, dosing, monitoring, and some precautions when prescribing mavacamten in the clinical practice, and some pivotal trials in aficamten is a next-in-class cardiac myosin inhibitor. First, we start by lifestyle modification and prescribing beta blockers and calcium channel blockers as tolerated, and then we proceed for the next step is adding disopyramide, and the patient is still symptomatic with high-grade and really fair for septal reduction therapy. We have several limitations of the current medical therapy, that the impact on the current pharmacotherapy is unknown due to limited evidence. We have a lot of side effects hindering proper dose escalation, and importantly, they do not modify the underlying substrate. Limitations to septal reduction therapy being invasive in nature, carrying a high risk of complications, and for favorable outcome, we need access to high volume comprehensive centers, and this is not available for many patients. And the need for repeat procedures is also not uncommon. The mechanism of action of cardiac myosin inhibitor. To understand the mechanism of action of cardiac myosin inhibitor, we have to know in depth some about the molecular level of the HCM sarcomere, that we have extensive actin myosin cross-bridging and deficient superlaxis state of myosin. And what the cardiac myosin inhibitor do is that they stabilize the superlaxis state, attenuating the hypercontractility, decreasing the extensive cross-bridging, attenuating hypercontractility, improving compliance and myocardial energetics. The interesting thing about the cardiac myosin inhibitor is that they target the underlying pathophysiology of HCM, they are reversible, and they are cardiac specific. And the last point is quite important because this gives them low probability to cause unwanted non-cardiac side effects. The mavacamten, the first-in-class cardiac myosin inhibitor, and the aficamten, the next-in-class cardiac myosin inhibitor. I'm going to discuss some pivotal trials on each. Explorer HCM was the first phase 3 double-blind placebo-controlled study performed on mavacamten. It was on multi-center, 68 centers from 13 different countries. Symptomatic obstructive HCM patients were included, and 50% of the population received mavacamten versus placebo. The primary endpoint was objective improvement in VO2 max with or without improvement in NYHA class. And the impressive finding result was the primary endpoint was met, and 37% of the MAVA group had significant improvement in the VO2 max, along with improvement in symptoms in terms of NYHA class. The second endpoints were met as well. The LVO2 gradients went down, VO2 max increased, NYHA class improved, and the quality of life as well as improved remarkably with significant results. This slide showed that both the resting and the provocable gradients decreased significantly in those patients receiving mavacamten. And with regards, in terms of anti-failure medication, the Explorer HCM demonstrates that mavacamten had a quite marked effect on the quality of life compared to other anti-failure medications. The long-term extension study, those patients were allowed to receive mavacamten for up to 120 weeks and showed sustained improvement, and at least 2/3 of the patients continued to have symptomatic improvement, modest symptomatic improvement, and a minority had significant symptomatic improvement as well. On the left-hand side here, we have the left ventricular ejection fraction initial drop during the treatment period, but afterwards we had a stable reduction in left ventricular ejection fraction, and all remain within normal range. On the right-hand side, we have the cardiac biomarkers declined significantly, reflecting relief in myocardial stress after receiving the medication in the initial period. So another interesting part of the study that focused on observing the effect of mavacamten on the cardiac structure, function, and fibrosis. A small number of patients underwent CMR looking for if the mavacamten affects the indexed left ventricular mass, and the impressive result was that yes, it does. It decreased left ventricular mass index, wall thickness, and atrial volume index, left atrial volume index, but no effect on late gadolinium enhancement over this short period of time. So the interesting part is that those are all predictors of poor prognosis. And this provokes another important question, a couple of important questions actually. If the mavacamten or cardiac myosin inhibitor have any prognostic value, or how much could they influence the sudden cardiac death risk score? And the robust study needs to be conducted before declaring any. And the very next question that approaches our mind is that will the cardiac myosin inhibitor serve as an alternative to septal reduction therapy? VALO HCM study, it challenges this part particularly by involving the patients who are eligible for septal reduction therapy, started giving them mavacamten incremental doses compared to placebo, and the results were astonishing that 82% at the end of the study were no longer eligible for septal reduction therapy. This slide showed that both the LVO2 gradients went down. The resting and the provoked LV gradients went down in the MAVA group compared to the placebo, with only minor impact on ejection fraction. Well, this also reflects the improvement in NYHA class, and the quality of life were also improved in the MAVA group. This slide shows the cardiac biomarker, how the cardiac biomarkers went down after receiving mavacamten, reflecting again how myocardial stress has been improved after taking mavacamten. The VELO HCM crossover trial where the placebo arm were allowed to receive mavacamten as well, and the results were as expected. Those placebo arm received the mavacamten had similar results like those in the original group. And the interesting part about this slide is that here in the this arm whom were and kept mavacamten from the start had a sustained effect throughout the study. So going to the safety of mavacamten, only concerns were raised. The most concerns were raised on significant drop in ejection fraction that was reversible in the majority of cases. So it's advised to keep a close eye monitoring ejection fraction during the therapy. The most recent EC guidelines included advised to consider giving mavacamten for patients who are eligible for septal reduction therapy. So next slide shows where do they fit. For those patients who received conventional medical treatment, beta blocker, calcium channel blockers, and still symptomatic and now proceeding for septal reduction therapy, give a chance for mavacamten, consider mavacamten before proceeding for invasive strategy. I'm not going in depth to explain the initiation and titration, but I wanted to highlight from this slide that starting dose 5 milligram and over the initiation phase is about around 3 months. There's no room for dose escalation, but only to test the tolerability for the medication. Treatment interruption is recommended at any time if the ejection fraction dropped below 50, and if the gradients are still high. We have to do periodic echo first to check the ejection fraction and LVO2 gradients. If the gradients are still high and we have good contractility, there's room for dose escalation. If we have ejection fraction that's greater than 50 but it gets in below 30, no need to make any dose escalation. The second thing that I want to highlight here is that they are contraindicated so far, not recommended to be given to pregnant ladies. There is a risk of fetal toxicity, and if the lady received the mavacamten already, she's advised to take contraception for a 4-month washout period before planning any pregnancy. The second in class, aficamten, the Red-Hot HCM cohorts 1 and 2 is involved with patients with obstructive symptomatic HCM and started giving them aficamten 2 different doses compared to placebo. And the results were as expected. Those patients received the higher doses of aficamten had better symptomatic improvement and better lower LVO2 gradients. 93% showed complete response in the cohort 2, those receiving the higher doses of aficamten. Cohort 3 made another challenge by giving aficamten along with disopyramide, so the patients are now receiving 2 negative inotropes. No major dose escalations were made, but the important about that is they tolerated both negative inotropes with no major systolic dysfunction occurring. Sequoia trial is a pivotal study on the aficamten as equivalent as the VELO HCM and mavacamten. In case of mavacamten, it involved quite considerable number of patients, 282 eligible for septal reduction therapy, and declared a primary endpoint that it objective improvement in peak oxygen consumption per cardiopulmonary exercise. The study has ended, but details of results hasn't been announced yet. But top-line results show that improved exercise capacity, increasing peak oxygen uptake, and improvement also was seen in all pre-specified secondary endpoints, including quality of life, symptom improvement, LVO2 gradients, exercise workload, and the guideline eligibility for septal reduction therapy. So in summary, shared decision making is the key to most favorable outcome, weighing benefit and risk, and to choose either way. Mavacamten is the only approved cardiac myosin inhibitor so far, and the aficamten is on the way, and we need close monitoring for systolic function as the key. Question yet to be answered is the long-term efficacy, safety, and the cost effectiveness of that treatment. Could it serve as an alternative to septal reduction therapy, at least for those patients who aren't a good candidate for intervention? Is there any survival benefit that's comparable to that seen with septal reduction therapy? Will it be effective against certain mutations but not others? And could they halt or slow down the disease progression at any at any time, and would they prevent latent disease before development of a disease. Thank you.
هو الكومباريزون مع سيبتا ريدكشن ثيرابي مال السيرجري مش كونسيدر يعني
لا الكومباريزون ريت مع سيرجري
مع السيرجري the need for septal reduction.
دي وير
هل في اي ترايلز مع كامتين على النون اوبستراكتيف فور
يس
مثلا ريديوس البروجريشن تو هارت فيلر
في فعلا some trials على non-obstructive hypertrophic cardiomyopathy وفي اوديسي trials لسه ongoing على المافاكامتين. افيكامتين عملوا ريدوود اتش سي ام كوهورت 4 بالفعل بس still not recommended to give them عشان ما كانش فيه النتائج المتوقعه وكان كوهورت سامبل كوهورت سايز ما كانش الكبيره اللي يقدروا يحكموا عليه.
هل أحد من الأودينس؟ وما فيش جين ثيرابي لغاية دلوقتي.
ما فيش جين ثيرابي لا.
شكرا دكتور أحمد.
The fourth speaker, Professor Muhammad Hosni from Cairo, will talk interventional and surgical innovation.
Good afternoon, my dear professors and colleagues. It's a great pleasure for me to study this topic with you today. Interventional and surgical innovations. First of all, it's well known that a hypertrophic cardiomyopathy, it is the most common inherited muscular disease with incidence 1 patient to 200 persons worldwide. It's a growing area of research with a lot of debates and controversies in all its aspects of management. And we have, as you see, a long journey of advances starting in 1960 with the description of the first case of hypertrophic cardiomyopathy, passing through the intervention, first intervention of surgical myotomy by Moro in 1964, then 1995 with the introduction of alcohol septal ablation, and ending with 4 to 5 guidelines over the last 20 years. But we can see that there is a slow progression in the information that we have about HCM in comparison to more familiar diseases like heart failure. For example, heart failure, we have guidelines every 2 to 3 years. But in HCM, it is slower than that. But even if it's with its slow progression, we can see that early HCM referral cohorts, they have mortality rate of 6% per year, which have been decreased after addition of all measures in management of HCM regarding medication, septal reduction therapy, prevention of sudden cardiac death, to be 0.5% per year, which is equal or less than the usual mortality rate as in US. And this converted the highly malignant disease into a more benign and stable with normal longevity. Also, when we can compare the mortality rate annual and the 5-year mortality rate for HCM in comparison to all cardiovascular diseases and non-cardiovascular diseases, it was the lowest one. When we are discussing hypertrophic cardiomyopathy, we should look for the management in a holistic approach, and it's not one-man show. It is a hard team job that include all the items, including adult and pediatric cardiology, radiologists, surgeons, special nurses, biomedical engineer, and the genetic teams. And we have advances in all aspects of the management of hypertrophic cardiomyopathy. The scheme of this presentation, we will go for Firstly, the guideline recommendation. What is the limitation of the management option, and what are the advances in these items regarding surgery, septal reduction therapy by its two wings, surgical and percutaneous, medications covered by Dr. Ahmed Dasuki, genetics covered by Dr. Mohammed Abul Aziz, and finally the basing options and sudden cardiac death prevention. If we started with the indication for surgery, all of us know that patient septal reduction therapy is indicated to improve symptoms only in patient with maximum left ventricular outflow tract obstruction more than 50% in the presence of marked incapacitated symptoms. NIHA function class 3 or 4. What about heart failure function class 2? Like this patient, it's a 50-year-old male patient presented with rapid atrial fibrillation, diagnosed as hypertrophic cardiomyopathy, and after restoring sinus rhythm, he has dyspnea NIHA 1 to 2, with a BNP 1,600 picogram per deciliter, with a resting LVT gradient, as we can see here, is about 100 millimeter mercury at rest. This issue was studied in this nice study in which they compared the outcome of patient. It's an observational study. The outcome of patient who underwent septal reduction therapy or myectomy according to class 1 indication, NIHA function class 3 to 4, or to go earlier with NIHA function class 2. And they found that going earlier with surgery in patient in the blue color with NIHA function class 2 have a more favorable outcome than the other group. And this is our patient, have a very nice left ventricular outflow tract with no further atrial fibrillation. He became asymptomatic with no further admissions due to his AF, with BNP 107 picogram. And it was mentioned in the guidelines that in the presence of atrial fibrillation, we can go in this type of patients in highly expert centers. And I think the BNP should have its chance to be present in the indication for intervention for these patients. What about the indication for septal reduction therapy? All of us know that we have the two wings of the septal reduction therapy, either myectomy or alcohol septal ablation. Myectomy has the advantage of procedural success more than 95% and with less need for pacemaker insertion. And every type of intervention has its pros and cons. Some of our patients who are high risk for surgery can go for alcohol septal ablation. Also, septal myectomy is more preferred when we have an intrinsic mitral valve disease or presence of coexisting disease that require surgery like CABG. Here in this video, this is one of the cases that is done in Aswan Heart Center, in which we can see the obstruction here. And it underwent the usual transaortic median sternotomy septal myectomy. And we can see here the part of the myocardium that is removed. And we can see the nice result at the end of this video with abolishing the left ventricular arterial obstruction. But we have a limitation for the surgical transaortic myectomy, which is sternotomy, the presence of extracorporeal cardiopulmonary bypass. Sometimes it's limited to centers with high level of expertise. High surgical risk patients cannot undergo these types of surgery. And sometimes we have inaccessible sites inside the ventricle, like the mid-ventricle and the apical hypertrophy, which is not accessible through trans-aortic approach. We have many invasive surgical instruments that can be used to go for myectomy with very acceptable level of complication. And even it is reproducible and they can go for mid-ventricular obstruction. In this nice study, when they compared the results and the outcome for the different surgeons, they found that there was no statistical significant difference between the outcome between the surgeons, which means that it is a reproducible and it does not need a very lengthy time to learn it. What about the mid-ventricular and the apical hypertrophic cardiomyopathy? We all face all these patients. They are highly symptomatic, no role for alcohol septal ablation with a very poor long-term outcome, and the only solution is heart transplantation. Does he have an option? Yes, we can combine transaortic and transapical septal myectomy with acceptable level of complications, and we may end with this very nice left ventricular cavity. In this nice study, who have apical hypertrophic cardiomyopathy and they are waiting heart transplantation, they compared 108 patients who underwent apical myectomy, compared the outcome versus HCM patient, apical HCM patient who underwent heart transplantation already. And from 1993 to 2017, and they found that there was no difference in mortality between two groups. So, in conclusion, we can use apical myectomy for these types of patients. And we can end with this very nice LV. We have, for the sake of time, I will jump some of the techniques, surgical techniques. Regarding the other wing of the story, which is alcohol septal ablation. Alcohol septal ablation is the standard non-surgical technique for these patients, but we have also limitations. Coronary anatomy sometimes unsuitable, high rate of pacemaker insertion, escape of the alcohol into different sites may induce damage to other sites of the myocardium, and sometimes the edema of the tissues after the procedure may temporarily increase the LVOT gradient. What are other options? We have the CSAME operation. What is the CSAME operation? It is, it uses the original surgical technique. The original surgical technique for hypertrophic cardiomyopathy is just to do incision in the LVOT, not to remove the muscle. So by two catheters, we can introduce them through sheaths in femoral approach or radial approach. We can go with the CTO wires guided by the microcatheters inside the myocardium and to do electrosurgery and cause myotomy. And this is, will be the result of this procedure. It leads to widening the LVOT area significantly. Other one of the methods that can be used in myectomy, this is very recent, is this transapical beating heart septal myectomy. It's a special device, can be inserted transapically to the desired area while the heart is beating. So we have all the time monitoring of the hemodynamics, and we can adjust our myectomy according to the needs of the patient. This device end up with the pieces of the myectomy according to the needs of the patient without causing left bundle branch of nerve, with accepted result as a complications and in all labs, echocardiographic parameters and other parameters. Another type of intervention, which is the radiofrequency ablation. Radiofrequency ablation, this idea, ablation for the muscle, this idea was taken from the radiofrequency ablation for the arrhythmias. It was first done by endocardial ablation, and it was and this was guided by 3D carto in order to avoid the injury of the conduction system, and it has acceptable result. And it was modified to be to be done with under echo guidance. And finally, we have the myocardial ablation, not endocardial, by certain needles that can be inserted transapically to reach the area desired in the septum, 3 millimeters away from the left bundle branch, and 8 to 10 millimeters away from the Hess of bundle that can produce necrosis of the myocardium without causing conduction abnormalities with acceptable result. The previous one, it was done in only 25 patients. This was reproduced in 200 patients with very acceptable results. What about the mitral clap in HCM? As you all know that mitral valve apparatus is highly involved in the pathophysiology of the left ventricular outflow tract obstruction. So clipping the both mitral leaflets can restore the mitral valve geometry and produce the mitral valve to be away from the septum and decreasing the obstruction. It was done in very high surgical risk patients. The mean age was about 80, and it was very effective in decreasing the gradient from 91 to only 12. This was done on only 6 patients. The medication was covered by my colleague. Genetic testing, I will not go through it. Lastly, the advances in pacing. Pacemakers, there was no advances in pacing regarding hypertrophic cardiomyopathy. As you all know that pacing is one of the measures that can be done as a palliative for patients who are not candidate for surgery or not candidate for alcohol septal ablation. And it have a mixed results. There is no consensus that it will be beneficial for the patient. So pacing, leadless, his bundle, left bundle are not beneficial for hypertrophic cardiomyopathy. Regarding sudden cardiac death risk prevention, does the subcutaneous ICD has any advantages for this type of patient over the transvenous ICD? Yes, because these patients are young age and they will have to do repeated extraction of the devices along their life. But on the other hand, the main disadvantage of this subcutaneous ICD inability to deliver anti-tachycardia pacing, high rate of inappropriate shocks, and inability to relieve the symptoms of LV obstruction by pacing, and also we cannot go for high doses of beta blockers in this patient because subcutaneous ICD cannot pace the ventricle. Regarding sudden cardiac death risk prevention, as you all know that we have a different strategies worldwide. We have the American one, which is all or none. If you have one criteria, you will go for ICD. On the other hand, the European one, which is based on the scoring system for items, and if you achieved a cutoff, you will insert ICD. The other challenge in this sudden cardiac death prevention is that all data are derived from an observational data, no randomized control trials in this issue. The third thing is that we have a worldwide heterogeneous applications. One patient can have a different decisions in different centers, as the experts are not going with the same strategy. And finally, we have an HCM risk for the children. Sorry for Tala. My take-home message after more than 1/2 century, we have the management of hypertrophic cardiomyopathy have changed substantially, and this is due to advances in therapeutics, diagnostic, and understanding the disease of the spectrum that makes the mortality decreased from 6% to only 0.5% per year. But still, HCM is a chronic condition with a lot of unmet needs that should be addressed. And thank you for your attention.